thank you all very much. And this, of course, arrives at such a crucial time, the start of the open enrollment season. Let me start with you, Ms. Hoagland. You gave us an example of what amounts to a jaw-dropping ripoff. You basically said that some of these plans are paying $1,300 or more for a new enrollee. Is it right that when you add all of these extra costs, all of the costs heaped onto the system by these middlemen, this comes to somewhere in the vicinity of $6 billion?
Yeah, I would say that that estimate might even be low. I mean, truly, I think it's really important that we're recognizing the amount of dollars that we're talking about here. They are quite significant at the benefits of perhaps, lower costs for taxpayers or additional benefits for enrollees. So as I said, that maximum commission of $611 per new enrollee, but we're continuing to see this growing trend in paying these field marketing organizations, these middlemen, as you call them, all kinds of additional fees. You can call technology fees, referral bonuses, marketing, health risk assessment, and on and on and on. The list of creative add-ons continues to grow. And so this has really become sort of an arms race and creating this anti-competitive environment where, to my colleague's point here, that folks aren't necessarily being enrolled in the plan that's right for them. They're being enrolled in the plan where the incentive lies. That's the largest.
And the reality is we want competition in the system based on coverage. I'm thinking my friend and I worked together back in 2009. We had a bipartisan bill, and Senator Stabenow was with us on it as well, that would have put the competition in terms of who would get the best for their health care dollar in terms of coverage and options. And that leads me to my last question for you. The way we stop the ripoffs in traditional Medicare, and I mentioned, when I was director of the Gray Panthers, I'd go to a senior's house, and they'd go to the back room and be kind of embarrassed and bring out 10, 15 policies that weren't worth the paper they were written on. They had these fancy subrogation clauses, and you basically got nothing. The way we drained that swamp is we had some core standardized principles around which traditional Medicare is offered. There's competition, but it's competition based on coverage, not who can win the arms race. Is that really what you're recommending here?
Yeah, absolutely. We want what you want, which is, sort of fair and equal competition. But competition ultimately is what is best for our seniors, and making decisions based on the benefits offered, right, not the financial incentives.
So you characterized it as an arms race. Paint the picture of what would happen if nothing is done. Supposing the Congress just says, we're very busy, we don't have time to deal with it, and they're making a good point over there in finance, but we got a lot of stuff on our plate. I share your view. I think there will literally be a healthcare arms race, but paint the picture of what that would look like.
Yeah, I mean, I think the first thing is we would continue to see add-on payments. As I mentioned, there already is a lot of creativity about what these things can be called, and I think we continue to see that number grow and grow if there's no caps or additional transparency. And then ultimately that starts to inhibit competition, as smaller regional plans in particular are not able to afford to keep up in that arms race and continue to make these add-on payments. And so I think that ultimately it does lead to less competition and not things that are in the best interest of the beneficiaries.
Mr. Blumenfeld-Ganz, just a question for you about ghost networks. And, my 10-year-old is always wondering why I'm always talking about ghosts. And, the point really is, 6-8 months ago, nobody knew really what this was about. But this is about as stark a ripoff as I can imagine seeing, because if, say, somebody in the audience or a family member buys a policy that they think will give them essential mental health kind of services, and then they go to get them, they find that nobody is there. There aren't any providers, and you don't get any information and services, and there may not even be a directory in terms of where to go. Why is this so serious? You've looked at this, I know, in considerable detail. Tell the committee why it's so serious.
There are a few aspects here, and it is a really serious issue. I think there are gradients of how this plays out in practice. On the one hand, on the far side, as you're alluding to, there are networks that just don't exist that are straight fraudulent. That is not legal today. It's an enforcement issue, not a policy issue, because that is not allowed based on the rules. But there's a really complicated gray area in the middle where you have networks that do exist, but there are no open opportunities for patients to schedule appointments for a host of reasons, either because the providers are overbooked and understaffed, or because the tooling isn't sufficient. There are a host of reasons. But I think even from the well-intentioned perspective, when there is good intention, it can still be very challenging for consumers. And so when we look at additional policies or regulations that we could consider, certainly better enforcement of the true ghost networks that just should not exist, and there should be better enforcement there. But I do think there's an issue as well of provider networks that do exist but are just really hard to access.
Great.